Hello, my name is Mike Sarap. The title of the webinar today is Cancer Program Leadership Skills, and we'd like to go through some tips and techniques for leading a successful team, and particularly in reference to the new 2020 Commission on Cancer Standards. I've been a cancer liaison physician for 30 years and a state chair in Ohio for about 6 years, and have done some extensive review of the new standards, and they are of significant change from the old standards, and I think that folks are going to like that. So the resources that I use for this webinar are the new COC standards, optimal resources for cancer care from the American College of Surgeons this year. I've also stolen some information from previous American College of Surgeons leadership summits and some COC presentations that provided some very excellent material about leadership and team building. And then I've got some well-established leadership resources from the business sector. There's no reason to reinvent the wheel in medicine in terms of building leaders of teams and of corporations and of organizations. This research has been done for decades, and there's some really excellent books out there that have been proven to help. And so we're going to kind of extract some of that information as we go along. So the Webster's Dictionary says a liaison is a communication or cooperation that facilitates a close working relationship between people and organizations, or one that maintains that cooperation or communication. And that's the crux of what a cancer liaison physician does and is. We connect our cancer team to the Commission on Cancer, other physicians on staff, other cancer committee members, the administration, the community. We are very involved in the Cancer Society, or at least we should be, and we should be involved in local and state cancer coalitions and other facilities that are caring for cancer patients in our region. It seems like a lot of work, but it all kind of segs together, and it fits together to make someone a really, really excellent liaison physician. And everything we're going to say today goes for a state chair, and it goes for the chairman of the cancer committee in your facility as well. Everyone is involved in wearing multiple hats. The standard is up there, 2.2. It's a new standard about who the liaison physician is. It's actually fairly simplified from the previous standards. Basically, it says you have to be an active member of the medical staff. And the new thing about the definition of a CLP is that we are deemed the physician quality leader of the cancer committee and the cancer program. We oversee the committee meetings if the chair is gone. There is that rule that says that you can have a CLP and the chair of the cancer committee in the same person. It's discouraged, but in small facilities, many of us have to wear many hats, and so they do allow that. And so the CLP is the quality champion. And so we are asked twice a year to identify, analyze, and present data from the National Cancer Data Bank that's pertinent and specific to our specific program. Now that standard has changed. Before we had to do that quarterly at each quarterly meeting, and now we just have to do it a minimum of 2 meetings. And we're going to talk about how we do that, what exactly should go into that report. The CLPs are given this free access to the NCDB reports that include survival reports and benchmarks and other types of cancer program performance reports, so that we can compare ourselves to other programs. And it's an incredible array of data that we can compare ourselves to people in our own state, people in the same size facility, and we can compare ourselves to every COC program across the country. And so these reports that we give to the Cancer Committee, they have to be based on data from the NCDB. And we'd like to focus on things that we perhaps aren't doing as well in as we should. The CLP also, when you have a site visit, your every 3-year site visit, you should be very involved in that site visit, meet the reviewer, and be responsible for presenting data. The CLP reports on Commission on Cancer activities and initiatives and priorities to the Cancer Committee, and really serves as that liaison between the cancer program, the COC, and the Cancer Society. All those things are important. So there are many standards. In fact, most of the standards that are truly supported by the cancer liaison physician, and we'll kind of go through these as the talk progresses, but I just went through and looked at each standard and said, geez, how can a CLP be involved in these standards, and should they be involved? And if you look, it's standards 2, 4, 5, 6, 7, 8, and 9. And again, we'll go individually through the program today about what do I mean by involvement and how can the CLP get involved with that. But it's really important that you understand the entire packet of standards as a CLP and be ready to help your cancer committee members, your cancer committee chair, and even more particularly your registrar to fulfill these standards. So how do you become a cancer liaison physician or state chair with the right stuff? Some of you may not recognize that group of individuals as the first American astronauts, and there's a book and a movie about them called The Right Stuff. These guys were all test pilots that transitioned into the very risky space business, and one of these was John Glenn, who actually was born where I practice and where I live in Cambridge. And so I thought it was appropriate to use that analogy. What kind of stuff do you need to be a good CLP or a good state chair or even a cancer committee chair? Well, I broke it down into people stuff, planning stuff, and professor stuff. And we'll start with people stuff. Truly, people stuff means that you have to be a leader for your cancer program, your cancer initiatives, and your cancer quality in your facility. And so there are tools out there that would help. Why do you have to be a leader? Well, number one, you have to be a leader to get people to the meetings. So attendance is really important and mandatory. You have to be an outstanding spokesman for the services that your cancer program needs, even though they may not bring a profit to your facility. Navigation is a great example of that. You have to lead the pack in terms of expectations and protocols and accountability measures, and you have to be very involved in that one big quality improvement project that we have to do every year, and then monitoring compliance with guidelines, quality improvement, education activities, and you have to be a leader in trying to get physicians to submit cases for clinical research trials. Some of these are very tough to do. The physicians involved with these patients maybe don't want to do these things, or they look at their results as being perfectly fine when they really aren't when you compare them to other. So you're going to need some leadership skills to help people. And there's this great book by Jim Collins called Good to Great. He looked at corporations in business over decades, and he tried to find these corporations that continue to improve, expand, and succeed, not for 5 or 10 years, but for 30 to 40 years. And so he found out the reason that these corporations did so well was that they had these people that were leading them, and he called them level 5 leaders. He also had a grading system for all leaders in business, going from level 1 to level 5, and you see the pyramid there. And we're going to talk about a lot of pyramids today, and I hope I don't bore people with pyramids, but it's a great analogy. He said that you can go from just being a capable individual as a team member and doing your job or doing what you're asked to do, then elevate that to being a contributing team member, and then you can begin to manage people competently. You're not great, but you get the job done. Level 4 is what most corporations and most organizations have. They have a leader that is fairly effective, but it's really rare and amazing to see the people that achieve a level 5 executive type of leadership. And what do we mean by that? Well, just a little bit more of the description. Level 1, you make contributions, you have skills, you do good work if you're level 1. Level 2, you make more contributions, you do a little bit better than the level 2. The manager organizes people and resources to basically get goals done. And that's where middle level people are in industry, and also most of our medical facilities as managers. Level 4 leaders are great. They catalyze a commitment to getting things done. They plan out a clear goal and a compelling vision, and you stimulate the group, and that's great. But these corporations that really, really succeeded, they had these level 5 leaders, and these leaders, they build enduring greatness in a couple of different ways. They have this huge professional will. They don't stop at anything until things are done. And then they have this amazing humility that we'll kind of just mention. So the will means that you create superb results. You're a catalyst in this transition from a good organization, a good cancer team, to a great team. There's this unwavering resolve to do whatever you need to do to get the best results. And ultimately for us, that means the best quality care for our cancer patients. And you set this standard for the entire team, and they understand that you're not going to settle for anything less. And then when things do fail, when things aren't going well, they don't blame others. They look in the mirror, they look towards themselves and ask, why isn't this going? Why haven't we met our goal? That's the professional will part of that. And then this personal humility. These people are very modest. They shun public attention. They're really not boastful. They're very quiet, calm, and so they rely on these principles that they live by every day, not particularly an amazing charisma to motivate people. And then everything is about the team. They channel all their energy and all their work into improving the team, and they want people below them to rise up to their level. And that's a real leader when they do that. And when they have success, when it's a shared success, they look out the window and they thank others around them, and they put that success on them. That's this personal humility that we talk about with a level 5 leader. Usual management team with a manager or a level 4 leader, you have a vision about where to drive the bus. You develop a roadmap, and then you find people to jump on the bus to kind of help you. Whereas this level 5 leader, he recognizes the best people in his organization. He gets them on the bus by hook or crook. Any way that he can get them on the bus, they build this team, and then they find out what's the best place for us to go. And in our case, how do we best care for patients that have cancer in our facility? The spectrum of cancer programs that people are listening in are involved in is huge. You can go from a very large hospital system that may be in several cities, regions with many hospitals in each region. You can have one large tertiary hospital with 4, 5, 10 vice presidents and all these things broken up into departments. And then you can have a small community program, much like mine, where you have a cancer team and very little else. So this is an example of my program. Basically, we have a cancer center. The oncologists are there and the oncology nurses. We have a hospital where most of the work of the cancer committee in terms of our accreditation gets done. That's where our registrar is located. And we have the physicians and surgeons that work in the hospital, and it all feeds back into our cancer program. Pretty simple deal when you compare to this large program in Toledo that has several regions and several hospitals within those regions. It's really tough to lead a team like this, as opposed to my team, where I know everybody by their first name. We've worked on them for a long time. And so sometimes it's easier to get things done in small places, and you need much more leadership skills at the bigger places. And so a resource that really works great, it's a weekend read. It's a gem of a little book called The 5 Dysfunctions of a Team by Lencioni. Again, we're going to talk about a pyramid, but it goes and you build on the basis of these deficiencies that teams have. And if you could fix these deficiencies, you end up with a sterling team, an award-winning, high-performance team, and you have great care for your cancer patients. So we'll go through these dysfunctions. It's an absence of trust, a fear of conflict, lack of commitment, avoidance of accountability, and inattention to results. If you look at this pyramid, you talk about accountability and results. Well, that's the cancer program, and that's the cancer standards. And so that's why this relates really nicely to it. These dysfunctional teams, everybody acts invulnerable, especially in the big city. You have a surgeon or a radiation oncologist who knows everything and doesn't ever admit that he's wrong or they're wrong. So this invulnerability really causes an absence of trust. You have artificial harmony. Everybody thinks they get along during the committee meetings, but under their breath, they're really upset about somebody else. They're unwilling to bring up that they don't like the way the program's going. At the end of the meeting, there's ambiguity about who's responsible for what. So you have a lack of commitment, and then you don't hold people accountable to, and so people have low standards, low results, and you don't pay attention to that, particularly if maybe it's the chief of surgery. He's really not getting very good results. How do you fix that? How do you get past status and ego to bring him into the team and to look for team results. You can grow these things. Firstly, you have to open up and be vulnerable. If you're a new CLP or a new COC state chair, ask people, say, I'm not sure about this. I don't know how to do this. Or ask your registrar to help you through the data links in terms of getting data, extracting data. I'm sure that you know things that they don't know that you can help, but many people, if they're new, they need help. So be vulnerable. Try to create true harmony. Ask for advice, ask for differing opinions before you make a decision. There are lots of tools you can use in a committee meeting, but look around the room and look at people's faces, and you can tell if they agree or not. Set very clear goals, maintain high standards, and if you want accreditation, the standards are right in the book, and they're high, and they're to do the right thing for the right patient, and you want to do it in terms of a team. Focus on results in terms of a team. So the role of the leader is to go first, to look for conflict, mind for it. You want people to bring up if they don't agree with what you're talking about. You want to force clarity. You want to confront difficult issues, and you want to focus on collective outcomes. As you go up the pyramid, sometimes the tasks are a little bit harder, especially at the top of the pyramid where somebody's really not performing. And how do you bring that up to a surgeon that he's really not performing up to the standards that others might be? So conflict, it's very clear that when a group of individuals make a decision, it ends up better than one person making that decision, unless they are not able to practice open and honest debate in their organization, if they don't have healthy conflict. So the team leaders need to set this example. Sometimes emotions get pretty high, and in all honesty, I think some of the new standards in terms of the synoptic operative reporting, there are going to be some high energy discussions with surgeons in terms of changing their behaviors. And so team leaders can take an example with emotional intelligence and reflecting. When things get heated up, back off, take your time, let people cool down, and feel about what you're feeling, thinking, and doing, and then reframing it, the argument or the discussion, in terms of where do you think other people are coming from and why they're upset about that. I think everybody on this call has already heard about emotional intelligence. It's on everybody's lips over the last 10 years. It grew out of a book by Daniel Goleman, again, from the business world. And if you haven't, I would encourage you to get involved with this, read the book. But it's 4 sections: self-awareness, when you can read your own emotions and recognize their impact on others. Once you understand what your emotions are, the second is to be able to control those emotions, particularly at a heated meeting, and adapt to changing circumstances with your emotions. And then as you rise up, you become socially aware. You can sense other people's emotions and react to their emotions in an appropriate fashion. And then, just like a level 5 leader, you have these social skills that you can inspire others with this compelling vision and help others develop into great team members by offering feedback and guidance. But I think emotional intelligence is incredibly important for anybody that's in a leadership role. Commitment is on that pyramid. A team that commits, you have to really, really have clarity about where you're going, what people need to do, what things. You have to have common objectives and keep those objectives and goals and visions in mind for the whole team. Talk about your mistakes and learn from them. Act early on potential opportunities and move ahead without guilt. The nuts and bolts of commitment, just some things you can take away from this, is that summarize key decisions and actions to be taken in your minutes and talk about it before you leave. And then also establish deadlines, and in front of the whole committee, assign these tasks to individuals on the committee so that everybody knows who's responsible. In terms of the business world, that's called getting the monkey off of your own back, is that you put that monkey on somebody else's back to complete a task, and you put it in the minutes. You discuss contingencies, and so you take that fear out of particular failure. And the team grows by success and by congratulating each other and enjoying this. And so you start with low-hanging fruit and things that are pretty easy to grasp and easy to attain. Accountability is really important. There are accountability measures for the COC, and this ensures that poor performers really have to feel pressure to improve. And we'll talk about some tips to do that later. Identify potential problems by questioning people about their approach. in a way that they don't feel like they're being attacked. And then you establish respect for the people around you that are going along with the standards and attaining the quality type of care that we want. And then we want to be a productive team, so you focus on these collective results. You keep people that are achievement oriented on your team. You try to minimize individualistic behavior. You want team behavior, and you enjoy success and failures as a team and learn from them. And it benefits the team, and the productivity benefits from people that are team players. They're not looking out for their own advancement or their own accolades, and you try to avoid distraction. So we'll say, well, how do we do this? So you spend time with people. You identify individuals' weaknesses and strengths and play to that. Conflict is good, and so you encourage that. Review commitments at the end of every meeting, as we mentioned. Explicitly communicate goals and keep focused on these tangible group goals, and try to pull people into the fold that may not be doing as well as you'd like. And so some of these conversations are going to be very difficult. And I wish that every one of you could have this at home on your desk or at your office. This is a book that's been used by every executive called Crucial Conversations. It basically is a resource or a tool book. They go through almost every scenario you can imagine that might mean firing an associate, firing a subordinate, disagreeing with a boss, having conversations with a partner. And there are some great conversations that would apply to how do you address a surgeon that really is not following the standards, is doing things the way they did it 20 years ago. And so crucial conversations are defined as conversations that have opposing opinions with strong emotions, and there are really high stakes during these conversations. The stakes might be whether you get accredited at your next COC review. And so the book leads us by hand through this system where you start with heart, meaning what do I really want out of this conversation? What am I able to settle with? What are the things that I absolutely cannot live with? You learn to look during this conversation. There are people in the room that suddenly become silent, or they become red in the face and become silent. You know they're angry, and those are obstacles or barriers to coming to some mutual benefit. And so it's really important to look for those things. You want to try to understand the things that make this conversation and this meeting safe, in terms of apologies if you did speak out of line, or contrasting others' opinions, to be able to find that common ground. And then finally, you have to state exactly where you're coming from, what your path, and there are a couple of mnemonics under that you can look at later. But basically, in terms of sharing your facts, tell your story, ask others for their stories or their opinion of what's going on. You can rephrase what you think you hear from the other individual. And so you would hope that you and the other individuals in the room are coming with those same tools, with those same resources, that they can approach this very difficult topic in the very same fashion, so that you can come to this pool of shared meaning. It may not be exactly what you want every time, but something you can settle for, and it would be the best benefit for the entire group. So I would encourage everybody to have that on their desk and kind of look through that. And then eventually, if you're a chair of your cancer committee, if you're a CLP in a small program, you're going to have to go and ask your CEO or go to the C-suite to ask for things for your program. And so somebody came up with the 4 Ps that I think are great to have in your mind before you walk into the CEO suite to ask for something. And that's priority. You really need to understand what the mission of your organization is in your community. Is the number one thing on the mission academics and research, or is it community care, contributing to the community? Align your asks, your requests, along with those mission and the vision of the organization, and you're really going to have a much higher chance of succeeding. You really need to know where the politics and the power lie before you go in. Some of these C-suites are going to be in a room with maybe 8 vice presidents and the CEO. Know ahead of time who's responsible for the cancer program. Try to navigate through those sources of power. You need to anticipate the no's before you get in the room. They're going to say no, And you also have to bring solutions to those no's. So just don't bring a proposal. Look at the downside of what you're proposing in terms of the organization and already have solutions for them, which would help you navigate those barriers. And then it's going to take perseverance. You may not get it done on the first trip. And so you have to keep it on their radar with memos and supportive evidence that says we really need this. And some of the examples of what we really need that you have to go to a CEO, navigation is a perfect example. No hospitals profit from navigation, or it's very difficult to prove it, but they elevate the care of the patient. They elevate efficiency of a program. The patients absolutely love it. You get more in-migration of cancer patients with good navigation programs. Rural places are benefited by telemedicine and technology. You want to be able to get the right people on your cancer committee. And so sometimes that means asking these vice presidents, can I get this person appointed? And you have to have examples of politics privileging and the standard of care in terms of going to the C-suite, understanding who's going to be on staff and how they get privileges. And then probably the most important thing is, as cancer providers, we want to do the right thing. The COC says that. One of their major projects is to identify barriers to care. And these are individuals that can't afford care or can't get to the facility. So doing the right thing is something that many times you go to the CEO and ask, we really need to do more in the digital care. We have to find some way to get transportation. We need more cancer screenings in the community. Those kinds of things are what we need to be the sponsor of in the C-suite. So don't forget the 4 Ps. Planning stuff. What I mean by planning stuff? A lot of the COC standards require us to find quality initiatives, to find studies to do that we can improve ourselves on. We have to define certain goals for our program, even though those goals have been decreased, which is great for us that are trying to fulfill these standards in smaller programs. So we have to understand the entire cancer program. CLPs can't work in a box. We have to really understand the whole program. So how do we do this? And so the planning, the goals and projects and studies are involved in almost many of these standards, 4, 5, 7, 8, and 3. We talked about there's got to be some sort of a project or a study about genetics each year. There are these expectations and protocols. There has to be the big one quality improvement initiative. We have to have cancer program goals. And then we have a project about barriers to care in 8.1. And we have to figure out what kind of screening or prevention programs. The new standards are absolutely great in terms of simplifying the standards and simplifying what the requirements are. And I'd encourage you to kind of read them page by page. If you've been around for a number of years, I would consider this a radical departure from the previous standards. I think they're much more clearer. I think they're actually, the number of things that they're requesting of us are less, but there is a real clarity in these standards in terms of how do we solve the problems of addressing these. So planning stuff. So that means change, that particularly in physicians, but nurses, managers, all those things. And so healthcare is all about change. Physicians need to measure and report their outcomes. In the old days, we didn't have to. We just did what we wanted to do, and we kind of thought we did the best job of anybody. Transparency and public accounting is really important. The standards say that we have to be transparent and do public reporting of our results. Patient engagement and involvement in plans of care. And we have plans of care. We have to discuss that with the patient. We have multidisciplinary conferences that we discuss care among ourselves. And then reimbursement now is about quality and value and not volume. And I think that's where the American College of Surgeons, the Commission on Cancer, comes in and has a bright light, and that everything that we do is about quality and value. So if you want to be a champion, you have to be the expert, the educator, the connector or liaison, and the motivator for these things that we need to change. And these high-level leaders, these themes go over and over again throughout business or leadership in almost any industry that you look at. You have to see the big picture. They're communicators. They have unwavering focus on patients and quality. It's all about the patients. They have this communication ability to engage with others. Again, emotional intelligence, conflict resolution skills, and a lifelong commitment to learning. There's several studies out there that show hospital systems and hospitals that are led by physicians do better than hospitals that are not in terms of having one in a CEO position. And I think that's because there's an unwavering focus on patients and quality first, and then financial aspects later. So we have to be champions. We have to be high-level leaders. There's a great example of a book that would help us lead change by John Carter, again, from the business world, and he breaks it down into steps about how do you change. There's this establish a sense of urgency, and then you find a coalition, find people to jump on the bus. You have to have a vision and a strategy, and we'll talk about vision in a little bit. Communicate that change vision to other people, and you empower your team members to go and act, to do the best thing they can to get to this. That's that level 5 leader, that he improves the people around him. You celebrate, generate these short-term wins, and you try to anchor these new approaches in the culture. Establishing a sense of urgency is really important. Sometimes people talk about a burning platform, where you're out on an ocean, on an oil platform, and it's burning and you need to jump. We need to kind of light a fire under folks to make them understand that we have to change or we're going to fail. We're not going to do well. So you create this climate for change. You engage and enable the organization to do that by bringing in a team and growing that team. And then you implement and sustain the change little by little, and it gets done. What kind of a vision do you have? A little story that I have, I look out the back of my hospital, and we have breaking ground for a brand new cancer center. And we had this vision 5 years ago. We're a small rural hospital. And 5 years ago, in the ensuing years, the year before last, we lost $4.5 million as a hospital system. Yet, we continue to look at the need for cancer patients, the need that the cancer service line is very profitable for a hospital. And last year we made $4.5 million because we changed. We got new leadership, and we tightened our belts, and we really looked and see what we needed and what we didn't. And lo and behold, in the back window, I look every day and see a construction crew putting up a new cancer center. 5 years ago, we imagined and we desired that we needed a new cancer center. We were having people sitting right next to each other, getting in chemo chairs, and not enough, and they were crowded and cramped. We knew that it was feasible, that our community would support that. We stayed focused. We started out with a 2-floor or 3-floored building with much higher cost, and we're flexible. And now we have a 1-level building that's going to do the job just as well with less of a cost. And we communicated this vision across the community, and it's going to happen. And next year, we're going to open the doors to a brand new cancer center for our patients because we had an effective vision and we're able to act on that. So there are some people that they're very difficult to change. And there's this cool little book by two brothers, the Heath brothers, about how do you switch. And he talked about people that you're dealing with as the elephant and the rider. Each of us has a little elephant and a little rider in ourselves. The elephant is that compassion, emotional, touchy-feely self that you have to inspire inside people to go on a mission, to get the things done. And the elephant's pretty big, and when some missions fail, most of the time it's because you don't instill that passion in people, and the elephant's going the wrong direction, and the rider wants to go another way. The rider is the rational self. He seems to hold the reins, and he thinks or she thinks she's in charge. And that's the one that thinks rationally. They have long-term plans. They can think beyond the moment, and they're more rational, less emotional. But again, when projects fail, it's because the elephant is going the wrong direction, not the rider. And so we have to address both the rider, that conscious verbal thinking stuff, and the elephant who's Mr. or Mrs. Emotion. So it has to appeal to both. If you reach the riders, they understand without motivation. If you only reach the elephants, they have passion, but they're not sure where to take it. So you got to direct the rider, motivate the elephant, and shape that path to get your vision accomplished. And they talk about this in the book. With the rider, you follow the bright spots, you script the motion because they're rational thinking, they want to follow a path, and you point where you want to go. The elephant is different. You have to motivate them. They have to feel it. You have to shrink how much change they feel they have to go through, and you have to grow people. They have to begin to grow outside of themselves to understand that they can be better. Shaping the path, you tweak the environment, you build the habits, and you rally the herd. So what are some examples of where you got to move the elephant and the rider? Quality improvement projects, people don't like change. Changing protocols to follow evidence-based guidelines. If people are not following these, we need to convince them differently. People that are operating without neoadjuvant therapy, if it's appropriate, who's doing pancreatectomies? Are they only doing 1 or 2 a year and somebody else is doing 20 and they're getting better results? Are we not asking our palliative supportive care folks to be embedded in our programs, which helps all of us? Some oncologists, think that's pointing to failure when they have palliative care, see them early, and it's really not. It's a team approach. And I think that synoptic operative reporting is going to be a real change that we're going to have to use every tool in our toolbox to get surgeons to follow along. So there's a little radio program on National Public Radio in the old days called Lake Wobegon by Karras and Keeler. And he used to start the program, he said, Lake Wobegon is where all women are strong, all the men are good looking, and particularly all the children are above average. And it's kind of ludicrous, not everybody can be above average, but many people that deal with cancer patients have the feeling that they take care of these patients better than anybody else in the world. And as a surgeon, I can tell you that surgeons have that mentality and that mantra, and it's very difficult to crack that Lake Wobegon effect on surgeons. And there are some ways to do that. Daniel Pink talks about the secrets of motivation and gives us some clues. There are several factors in terms of motivating physicians to improve their care. There's some extrinsic factors that might be financial and working conditions and perhaps government mandates. There are the inside feelings about cognitive challenges, which we like, open-ended thinking, and their professionalism. Those are the things that go into whether we change things or not. And so as a leader, we have to inspire a collective purpose and a vision. And so how do we change behavior in physicians? Very, very difficult. Standardization of care, changing to evidence-based guidelines. You have to promote autonomy. They really have to think that they're doing this on their own and not somebody's forcing them. And probably the most important point in the whole talk is that you have to show physicians data. And that's why as a CLP, you have to be so enamored with the National Cancer Data Bank that you can pull this data out. The only way to convince a surgeon to change is that you put good, strong data in front of him, and you use his data compared to everybody else that does the same thing, and show them that perhaps he is better or he is not as good as the other folks. That was the only way to change them. You can't tell them, oh, this is the new standard and we have to do it. A couple of examples from my past is that when we started encouraging people to do needle biopsies instead of open biopsies for breast cancer, that's a standard, obviously. And we had 3 doctors that were doing it and 1 that wasn't. And we couldn't change that opinion until we sent out a graph, and it had every surgeon on there, but the surgeons were A, B, C, and D. And it had each one of our needle biopsy percentage, open biopsy percentage, and each surgeon got that list, and then the code was cracked for their own percentage. Their name was on it, as well as A, B, and D if they were surgeon C. And if everybody else is 95% and you're 95% open biopsies and everybody else is 5%, the next quarter, I bet that changes for that surgeon. We had the same issue about colonoscopy withdrawal times. How do you change people to slow down and do a better job? The same way, we reported on withdrawal weights as a reflection of adenoma detection rates, how many polyps people were finding. We report that out quarterly, and we send that information to all the surgeons that are doing endoscopies. The very next quarter after we started doing that, low man on the pole who was pulling the scope out too fast and not finding polyps improved significantly. That's what I mean about using metrics and comparing them to others. What doesn't work? Appealing to the greater good, empty titles, and you can offer financial incentives, but they better be darn good. So the third part of this deal is professor stuff. This first slide comes and only is recognizable by baby boomers and older. An old show called the Gilligan's Island, and there was a professor marooned on the island with them. For everybody else, this is professor stuff. What do I mean by that? Well, I mean data, understanding data, knowing where to mine it, know how to analyze it, put it together, and report it back to the Cancer Committee or to your community or to your reviewer when he comes to review your program. And so this is the professor stuff standards from the new standards 2.2. Obviously, we need to do 2 reports a year as CLPs that come from the National Cancer Data Bank. Cancer Registry Quality Control, you should be part of that. You should understand what's being reported, what's being sent in, and be part of high quality data being given to the to the COC. Accountability and quality improvement measures, understand how they're measured, review them, and propose changes so that you can continue to improve. Evidence-based guidelines. First, you have to know what the guidelines are, and then you have to review your cases for the year or have somebody in your cancer program do that. And again, it's numbers and data, and it's really important. And then the quality improvement initiative obviously is all about data, and you have to be a bit of a professor to do that. So I would plead with you that you have to be your cancer program's guru for the National Cancer Data Bank, and you can only get this, you can only understand this by embracing the NCDB, the data links, going into it frequently, and not just because you need to find something or you need to do a project. You just need to sit there if you have an hour someday and fiddle with it and click on things. If you fall behind, if you look on there and there are several colon cancer cases, less than 12 lymph nodes harvested, you can click on those cases that fell out, click on the case numbers, and have your registrar pull up those cases and find out what cases exactly are we not getting 12 lymph nodes on. You could compare whether it's the surgeon every time. You could compare if it's the same pathologist every time that's not maybe looking as carefully as they want, but you only can do that by mining it. And your state chair, the COC staff would be more than happy to help you with that. And so I would say embrace this. Failure is really not an option in terms of becoming very, very facile with the NCDB. It's the largest clinical database in the entire world. And it's an amazing array of things that you can use to help your patients. So if you go back to the most simplified thing in terms of quality improvement, which people have a hard time grasping, it's this plan, do, study, and act. Plan to look at data and change something that you do to improve your activity. Do it, carry it out, and then study the results of that. And then act to adopt the new change or tweak the new change or change it somehow if you see that it's helped, or trash it if it hasn't helped. That's kind of the simplest way. And then from the old standards, this is an old slide about studies of quality. We had to do several studies of quality before. Now it's that one big one. But you look for a topic, define criteria, compare data, summarize that, implement some sort of a change that improves something, and then you monitor the effectiveness of that improvement. And again, every step of the way, you need to document that in your committee minutes so that the reviewer can see what's going on. So the big quality improvement initiative, it's very clear, and this is where most cancer programs fail. Ours is one of that as well, is that we thought we were doing quality initiatives, quality projects, but they didn't fulfill the requirements of the reviewers or the folks at the COC office after we sent everything in, and we've had deficiencies and had to go back and tweak things. And so they've been very clear on the new standards, and I think that'll kind of help us understand to identify a problem, what's causing the problem, and how do we do that through a performance improvement methodology, and then implement a planned solution. And then we have to give reports on this quality initiative twice a year at the Cancer Committee. And these are the components: review data, identify the problem, write the problem statement, choose and implement performance methodology and metrics, implement the intervention and monitor the data, present it, the initiative summary, and then twice yearly updates. It's very clearly marked, and it should help all of us. And I would hope, and I think the COC has clearly said this, they're going to give us some examples of what kind of quality initiatives would be great to use in our own programs. And then specifically for the CLPs, there are these two things a year that are presented to the Cancer Committee. It's based on NCD data, but I think it's very cool that NCDB data is 2 years old, at least. And go and augment the data that you pull up. Ask your tumor registrar to pull up the data from last year or the year before that. Feed that into your report. There are statewide data programs that you can look into that would augment this report and kind of make it an all-encompassing kind of report that would really bring some knowledge to your cancer committee and affect change. Look for problems or deficiencies, particularly to look at, propose a reason for the problem, and make a plan to improve it. And in the old standards and a couple of programs that I attended, they gave us some help in terms of these CLP reports. Here's a big long one that kind of describes things at length about what should be in those reports and how do we make a report that fulfills the criteria. And then twice a year, this one says quarterly, but it's twice a year, you can use this simple little form to kind of fill in or jot down what's the title of my report, where did I go for the data, and there's a whole list of things that you can look at that you can choose from to study in that report. What was my topic? What was my purpose? And the data analysis was what? What did I find from this report by looking at the statistics? And in fact, do we have a problem? Is this something that we need to look at more, or is this something that we should do a quality initiative in terms of fixing this? And so it's really easy to kind of jot in how we do that, and then hopefully it'll be a good tool or a little crutch for the CLPs to get this report done pretty easily. And so that's kind of it in trying to mesh leadership skills on the new standards. Again, I think this is a fairly radical departure, and the new standards goes a little bit more along with the Red Book or the Quality and Safety Book from the American College of Surgeons, that they're trying to mesh all the various quality programs into one standard sort of form. Coming from a small program, I'm very encouraged about these standards, and my encouragement is spreading in that I think that we can pitch COC accreditation to much smaller, perhaps rural programs with this new set of standards that they can get a hold of, they can put their hands and arms around and actually fulfill. I think the COC has been very insistent on keeping patients local for their care as long as they have high quality care, and finding the appropriate tertiary centers for those complex patients. And that involves teamwork on a regional or national level. And I think these standards can bring us all together and improve and elevate the care, even the smallest of communities in our country, for our mutual benefit of our cancer patients. So I really appreciate the opportunity to talk to you. I'd be more than happy to take questions. My cell phone and my email are up there, and anytime after the webinar, you're welcome to reach out. And I'm not saying I know all the answers, but I've been doing this for a very long time, and there are many others that have as well that would be more than happy to help and be mentors in this path to high quality cancer care. So thank you very much.